Welcome to lecture on balance and proprioception training. I am Major Arun, and in this session we will discuss how sensory motor recovery is a cornerstone of rehabilitation following ACL reconstruction. This lecture will highlight the disruption of mechanoreceptors after ACL injury, why retraining proprioception is essential for long-term stability, and how we can use progressive drills to reduce re-injury risk. We will integrate clinical evidence with practical strategies, moving from foundational balance work to sport-specific and neurocognitive drills. By the end of this lecture, you will understand the role of ACL mechanoreceptors and joint stability and neurocognition. You will learn the guiding principles and progression of balance and proprioceptive training, moving from simple static tasks to complex, chaotic, sport specific environments. We will also examine how neurocognitive strategies can be embedded into rehabilitation at different phases. Finally, we will review objective tests such as Y balance and balance error scoring system, which help evaluate effectiveness and readiness for return to sports. These objectives ensure that you not only know the theory but also the practical applications in clinical settings. Let us start by clarifying three important terms. Proprioception is the sense of joint position and movement, essentially how we know where our knee is without looking. Neuromuscular control refers to the integration of sensory inputs that allow body to generate coordinated, stable movements under load. And balance is the ability to maintain body's position against the gravity, whether static or dynamic. Together, these three constructs form the foundation of safe and efficient movement, and all are disrupted after ACL injuries. ACL injury and reconstruction disrupt the knee mechanoreceptors, which are essential for proprioception. Without retraining, patients are at high risk of re-injury because joint position sense and reflexive stability are impaired. This disruption often leads to neuromuscular inhibition, delayed muscle activation, and poor dynamic stability. The result is not only slower the rehabilitation process, but also there is poor return to sports outcomes. Therefore, balance and proprioceptive training are not optional extras. They are critical elements of ACL rehabilitation. The ACL is more than a mechanical stabilizer. It contains mechanoreceptors that provide sensory feedback to the central nervous system. When the ligament is torn, these receptors are disrupted, and surgical reconstructions, while restoring the stability, does not restore neurosensory integrity. This leads to impaired joint reflex pathways, slower reaction times, and delay in regaining dynamic knee stability. Moreover, re-innervation of graft is incomplete, which increases the risk of re-injury even when mechanical stability appears restored. This explains why proprioceptive training is indispensable in rehabilitation. Research shows that deficits persist even after graft healing. Hamstring reflex are often reduced, and corticospinal excitability can be altered for months after surgery. Patient may show abnormal postural sway, poor limb symmetry, and delayed muscle activation timing. These deficits directly affect functional performance. Athletes may feel unstable, hesitate during sport, and fail to execute explosive movements effectively. This evidence underscores the importance of structured, long term proprioceptive training. The goals of proprioceptive training extend beyond simple balance. We aim to restore joint position sense so the knee can detect and respond to movement accurately. We work to enhance muscle activation timing and movement efficiency, making stability reflexive rather than conscious. We want to improve reactive stability during dynamic movements like cutting, landing, and sudden deceleration. Finally, we reduce fear avoidance and build movement confidence, both of which are crucial for a safe and successful return to sports. Balance training follows a clear progression from high control to variable, from variable to complex, and from complex to chaotic. Unstable surface are tools, not the end goals. Our ultimate aim is to transfer into chaotic, sport specific conditions. Complexity should increase not only through physical challenge but also through visual and cognitive load. Progression must be criteria based, not simply time based. This ensures that every new stage is earned by demonstrating control, not assumed by waiting weeks. Balance training must be integrated into wider rehabilitation timeline. In weeks 1 to 4, focus on foundational static balance beginning with eyes open and progressing to eye closed. Between 4 to 8 weeks, introduce unstable surface and perturbation challenges. From 8 to 12 weeks, move to dynamic single leg task that change of direction drills. Beyond 12 weeks, integrate sport specific reactive drills, including decision making under time pressure. This staged integration ensures that sensory motor skills develop alongside strength and endurance. Early stage drills should be simple and safe. We begin with weight shifting, mini squats on a stable surface, and tandem stance swaying. Progression can come from removing vision, for example, closing eyes during balance tasks. The aim here is not difficulty but quality, retraining the neuromuscular system to re-establish basic control. These drills from the bedrock for later dynamic progression. In double stance body sway, the patient stands with feet shoulder width apart and gently shifts weight forward, backward, and side to side. The trunk remains in upright position. This exercise activates proprioceptive pathways early, restoring joint position sense. Ensure slow, controlled movements, avoiding excessive trunk lean. In tandem stance body sway, the patient stands heel to toe, maintaining balance while shifting weight gently. The narrow base of support challenges stability and improves postural control. Clinically, it retrains neuromuscular coordination essential for single limb tasks. Guard against loss of balance, especially in early phases. In the mid stage, we add complexity by altering the surface or adding perturbation. Foam surfaces, gentle manual perturbations, or using a Bosu ball create controlled instability. Mini squats or single leg stance on these surfaces increase the challenge to proprioceptive pathways. These drills build adaptability, teaching the body to stabilize against unexpected changes, and they also enhance muscular coordination and prepare the patient for more dynamic drills later. The double leg rocker board drill involves standing on a rocker board with both the feet, controlling sway in sagittal and frontal planes. Knees are kept in extension with trunk upright. This enhances proprioception, dynamic ankle knee control, and symmetrical loading. Ensure safety with hand support initially. Single leg stance requires maintaining upright posture while balancing on the reconstructed limb. The focus is on hip stability, knee alignment, and avoiding trunk sway. This develops unilateral control and reveals any strength or proprioceptive deficits. Begin with short hold and progress to longer durations. In late stage proprioceptive drills are sport specific and reactive. Example includes reactive balance with ball tossing, agility drills that mimic game situations, and single leg hoppings. We also incorporate decision making tasks that combine cognitive and proprioceptive demands, such as reacting to visual or verbal cues while balancing. The goal here is to restore neuromuscular reflexes under conditions that stimulate the sport. Only once these skills are restored and athletes safely return to a competition. In perturbation training, the athlete balances on a Bosu ball while receiving external pushes or taps. This forces rapid neuromuscular reactions and joint stabilization under unpredictable loads. Clinically, it replicates sport demands and enhances reactive balance control. Always supervise closely to avoid falls. This progression adds ball catching tasks while balancing on a Bosu ball. It integrates proprioception, core stability, and upper limb coordination under instability. The dual task demand closely stimulates sports readiness. Maintain upright posture, focus on soft knee flexion, and avoid valgus drift. Prescriptive exercises can be close chain, where foot is in a stable contact with the ground, or open chain where the limb moves freely. Close chain drills are generally safer and easier in the early stages. Open chain drills are more challenging and force greater neuromuscular control, but they should be introduced in a later part of rehabilitation. Using a mix of both allows better sensory motor reintegration and a more complete rehabilitation program. Neuromuscular electrical stimulation or NMES can play important role in early rehabilitation. It helps re-educate muscles, particularly the quadriceps, which is often inhibited after surgery. By enhancing voluntary contraction, neuromuscular electrical stimulation prepares the patient for proprioceptive tasks. This means exercises are performed with the better activation and control. When used correctly, neuromuscular electrical stimulation can accelerate transition from passive activation to active functional strengthening. Clinical decision making must be guided by objective assessment. We must assess the limb dominance and monitor performance using tools like Y balance test or balance error scoring system. Asymmetry gaps greater than 10% between the limbs are red flags and must be corrected before return to sport. Feedback based training using mirrors, video replays, or pressure sensors helps refine movement qualities. This combination of clinical judgment and objective testing ensures safer progression. Without dedicated balanced retraining, the risks are higher. Patients are more likely to experience poor return to sports performance with hesitation, instability, and reduced confidence. Long term instability increases the likelihood of developing osteoarthritis. The risk of contralateral ACL injury is also higher. as the body compensates poorly without symmetrical control. Delayed neuromuscular recovery ultimately reduces the effectiveness of all other rehabilitation efforts. Several common mistakes clinicians make. Advancing to unstable surfaces too early can overload the system and cause poor adaptation. Neglecting bilateral training or failing to address psychological readiness leaves patient vulnerable. Relying only on internal focus cues rather than external task based cues slows learning and transfer to sport. And finally, progressing by fixed timelines instead of using criteria can create unsafe gap in rehabilitation. Avoiding these pitfalls is as important as prescribing the right proprioceptive drills. To conclude, proprioception must be intentionally trained after ACL reconstruction. It is not automatically restored by surgery or by strength training alone. A structured approach begins with stable task, progress to unstable, then to dynamic and reactive drills, always guided by objective criteria. Proprioceptive training should be combined with strengthening, plyometrics, and cognitive drills for complete rehabilitation. And ultimately, balanced training is what allows safe, confident, and successful return to play. These strategies are supported by growing body of evidence, including systematic reviews and clinical commentaries. Key studies highlight persistent proprioceptive deficits post ACLR and effectiveness of neuromuscular and neurocognitive training in restoring function. In practice, our role is to combine this evidence with patient specific factors on surgeons' protocols. For optimal recovery, it is essential to follow the rehabilitation exercises in the demonstrated sequence, beginning each session with a structured warm up and concluding with an appropriate cool down. This systematic approach ensures that each step builds on the previous phase, promoting safe, effective, and progressive rehabilitation. Patient videos and images shown in this presentation are used with prior informed consent. Jai Hind.